You expect sickness to be, well, a straight line, like falling dominoes.
Right, yeah. A very clear cause and effect.
Exactly. Like someone sneezes on a crowded train, the virus travels through the airborne droplets, you inhale it, and then 3 days later you're in bed with a fever. It's this very direct binary transaction.
We are so deeply conditioned to view illness as an external invasion.
Uh-huh.
It gives us this false sense of control.
I mean, we're building a wall against it, essentially.
Yeah, exactly. You can wear a mask, you can wash your hands, you can avoid that sick coworker who won't go home.
But then you look at something like a urinary tract infection, and that straight line just shatters. With a UTI, the call is coming from inside the house.
It completely upends that whole traditional pathogen-host relationship.
Mhm.
When the biological reality is that your own native flora is responsible for the infection, that sense of external control just evaporates.
And yet, if you look at search engine data, millions of people are asking the exact same fundamental question every single year. Like, is this contagious? Or did I catch this from someone?
Millions.
Yeah.
It's one of the most frequently searched medical questions.
So why is our collective understanding of this incredibly common condition so wildly inaccurate? Welcome to today's deep dive, where we are pulling from a fascinating document called the iMedix Report, Myths and Truths of UTI Contagion.
It's such a crucial report.
It really is. And we aren't just answering the biological question of contagion today. We are looking at how an independent platform like iMedix is attempting to actively dismantle these deeply entrenched medical misunderstandings for you.
Because the misunderstandings have real physical stakes.
Right. Think about the last time you were handed a prescription at the pharmacy. You were probably given, what, a 10-page stapled packet of 6-point font?
Oh, that you either couldn't understand or just immediately threw in the recycling bin.
Exactly. So we're going to explore what happens when that system fails, how those failures breed medical myths, and how we actually go about fixing the data. So let's start with the phrasing of the report itself.
Yeah, the title, Myths and Truths, carries a lot of weight, especially when you view it through the lens of public health.
Because we tend to think of medical myths as historical artifacts, right?
Yeah.
It's like bloodletting or miasma theory.
Right, but the reality is that the modern medical landscape is actively generating new myths right now, especially when a condition is as ubiquitous as a UTI.
And they are incredibly common.
Oh, massively. They affect more than half of all women at least once in their lifetime, and, a significant portion of men as well. The sheer statistical volume of patients creates this fertile breeding ground for anecdotal misinformation.
Which is wild when you look at the sheer volume of medical data we have access to right now. I mean, we walk around with supercomputers in our pockets.
You too.
You can pull up a double-blind clinical trial or the exact pharmacological interactions of any given drug in a fraction of a second. So why are these myths still so bulletproof?
Well, because access to raw data does not equate to scientific literacy. In fact, without a framework to process it, raw data often accelerates the formation of myths.
Okay, break that down for me. How does more information create more myths?
So, if a patient experiences the sudden, severe onset of dysuria, which is that painful burning sensation associated with a UTI, they immediately turn to the internet.
Naturally, everyone Googles their symptoms.
Right. But they aren't searching peer-reviewed urology journals. They're searching their symptoms on forums, social media platforms, unregulated wellness blogs.
And what do they find?
A fire hose of conflicting information. Terrifying stories of antibiotic-resistant superbugs, aggressive marketing for unproven herbal detoxes, and highly technical clinical jargon that they just cannot parse.
It's noise. It's just an overwhelming wall of noise.
Exactly. And human psychology dictates that when we are overwhelmed by noise, especially when we are in physical pain or experiencing anxiety,
You don't naturally gravitate toward the most scientifically accurate explanation.
no, you gravitate toward the most emotionally resonant explanation. The idea of contagion, the idea that someone gave this to me or that I caught it from an unclean surface, is highly resonant.
It provides an immediate, tangible scapegoat for the pain.
Precisely. It's much easier to process, I caught a bug from a dirty toilet seat, than my own internal ecosystem has been disrupted due to a complex mechanical translocation event.
Which brings us back to the core biological reality. To dismantle the myth, we have to establish the actual mechanism. And spoiler alert for you listening, no, a UTI is not contagious.
It is not.
You are not catching it from a toilet seat, and you are not catching it from your partner's respiratory droplets.
No, but the mechanics of what is actually happening are arguably much more fascinating than a simple transmission event. We have to look closely at the microbiology here.
Okay, let's get into the microscopic level. What is actually causing the infection?
The vast majority of these infections, we're talking roughly 80 to 90% of community-acquired UTIs, are caused by a specific strain of bacteria.
E. coli.
Yes, specifically uropathogenic Escherichia coli, or UPEC. Now, E. coli gets a terrible reputation in the press.
Oh, yeah, because we associate it with, like, massive food poisoning outbreaks and recalled lettuce.
Exactly. But the reality is that non-pathogenic strains of E. coli are a vital, peaceful component of your gastrointestinal microbiome. They live in your colon.
So they belong there.
They absolutely belong there. They help synthesize vitamin K. They prevent the colonization of truly dangerous external pathogens. They are your friends.
So if they're supposed to be there, doing the heavy lifting for our digestive system, how do they suddenly become the villain of the story?
It is entirely a matter of geographic relocation. The environment of the lower gastrointestinal tract is vastly different from the environment of the urinary tract.
Because the urinary system, the urethra, the bladder, the ureters, and the kidneys, is designed to be a highly sterile environment.
Exactly. So when the native E. coli from the perianal region mechanically translocates to the urethral opening, the biological context changes completely.
It's an opportunistic infection. The bacteria aren't, staging a hostile coordinated invasion from the outside.
Right.
They just got moved to a neighborhood where they don't belong, and they start acting out.
Well, acting out is a mild way to put it. Uropathogenic E. coli have specific evolutionary adaptations that make them uniquely suited to survive in the hostile environment of the urinary tract.
Like what kind of adaptations?
They possess these microscopic, hair-like appendages called fimbriae.
Fimbriae, okay.
Yeah, you can think of them as specialized grappling hooks. The urinary tract is a high-flow environment, right? Urine is constantly flushing downward.
So the bacteria should technically just get washed out?
They should. But these fimbriae allow the bacteria to anchor themselves tightly to the epithelial cells lining the bladder wall, completely resisting that physical flushing action of urination.
Oh, wow. So they literally latch on.
They latch on tight. And once anchored, your body's immune system recognizes the unauthorized presence and launches an aggressive inflammatory response.
And that immune response is the fire alarm. That's the burning, the intense urgency, the lower abdominal pressure that you feel.
Yes, exactly.
So the symptoms aren't just the bacteria causing damage, it's the collateral damage of your own immune system dropping bombs on the invaders.
The inflammatory cascade is incredibly intense. But identifying this mechanism, this internal opportunistic translocation, it immediately nullifies the contagion myth.
Because you cannot pass your internal translocation event to another person through casual contact.
No, you can't. It is a closed loop of your own flora.
Okay, but let's look at the elephant in the room. There is a very specific, deeply ingrained reason why people think this is contagious, and it has everything to do with sex.
Yes, the correlation between sexual activity and UTIs is incredibly high.
We even have the colloquial term honeymoon cystitis. Like, if a patient reliably develops a severe infection 48 hours after being intimate with a partner, it is entirely logical for their brain to draw a straight line and say, my partner transmitted a disease to me.
It's completely logical. But that logical leap is the exact intersection where the public understanding of microbiology completely breaks down. People routinely conflate urinary tract infections with sexually transmitted infections.
They lump them together because, well, the geography is adjacent and the triggering event is the same.
Right. But biologically, an STI and a UTI operate on two completely different paradigms.
Break down that paradigm shift for me, because if I am the patient and I am in pain, I don't care about the paradigm, right? I care about who gave this to me.
Let's start with STIs. An STI, whether it's chlamydia, gonorrhea, or syphilis, is caused by an obligate pathogen.
Meaning it's obligated to do what?
These are specialized organisms that have evolved to require human-to-human transmission to survive and replicate. They cannot live indefinitely outside the body, and they do not naturally exist in your healthy microbiome.
Okay, so when a person contracts an STI, a foreign organism has literally been introduced into their system by an infected partner.
Exactly. The partner is the direct biological source of the pathogen.
Whereas with a UTI, the partner is not the source of the bacteria. The partner isn't giving you their E. coli.
No, not at all. With a UTI, the partner is acting as a mechanical catalyst, not a biological source.
A mechanical catalyst. So it's about movement.
Yes, the anatomy is the defining factor here, particularly for female patients. In the female body, The anatomical distance between the anus, the vagina, and the urethra is incredibly short.
Right.
Furthermore, the female urethra itself is very short, typically only about 1.5 inches long. During sexual intercourse, the physical friction, the movement, and the pressure act as a transport mechanism.
It inadvertently massages the native E. coli from the perianal and vaginal areas directly toward and into the urethral opening.
Exactly. So the partner is essentially just providing the transportation for the bacteria's commute.
It is the mechanical transport of your own flora.
Yes. And this distinction is vital for patient education because it fundamentally alters how you approach prevention and treatment.
Because if you believe you have an STI, you are dealing with transmission, contact tracing, and potential reinfection from a partner.
Right, which carries a whole set of anxieties. But if you understand you have a UTI triggered by mechanical transport, you can implement behavioral modifications.
Like immediate postcoital urination.
Exactly. To disrupt that transport before the bacteria can use those grappling hooks to anchor to the bladder wall.
And we also have to separate both of these from vaginal dysbiosis, right? Because people throw yeast infections and bacterial vaginosis into this exact same confusing bucket.
They do, constantly.
Yeah.
And it creates massive diagnostic confusion for the patient. Vaginal infections like candidiasis yeast infections or bacterial vaginosis represent ecological collapse, not transmission or translocation.
Ecological collapse? That sounds dramatic.
It is on a microscopic level. The
Okay.
vagina has its own complex microbiome, heavily dominated by lactobacillus bacteria that maintain a low acidic pH.
So they're the peacekeepers.
Yes. When that environment is disrupted, whether by taking broad-spectrum antibiotics, hormonal fluctuations, or even certain harsh soaps, the protected bacteria die off.
Allowing naturally occurring yeast or other opportunistic bacteria to just overgrow and take over.
Exactly. So we have 3 completely distinct biological events.
STIs are foreign invasions, UTIs are opportunistic relocations, and vaginal infections are ecological collapses.
Perfectly summarized. Yet, because the symptoms can overlap, pain, itching, discomfort in the pelvic region, a patient trying to self-diagnose based on a Google search is basically throwing darts blindfolded.
Which brings us back to the core mission of the iMedix platform. When a patient is standing in the middle of that diagnostic confusion, they don't need a medical dictionary. They need an arbiter of truth.
Right.
The report highlights iMedix as an independent medical information platform featuring a comprehensive drug database and specialized educational resources. And that word independent feels like the linchpin of their entire model.
Oh, it absolutely is.
I want to dig into that concept of independence because, it sounds great on a marketing brochure, but what does it actually mean for the architecture of medical literacy? Why should you, as the listener, care if a database is independent?
You have to consider the historical context of where patients usually get their pharmacological information. For decades, the flow of information was heavily controlled by pharmaceutical manufacturers and the clinical hierarchy.
Right, you had the physician's desk reference, the PDR.
Yes, which was a massive, impenetrable tome of drug monographs written by the manufacturers themselves, aimed strictly at doctors.
And for the patient, information came in the form of direct-to-consumer advertising.
A 30-second television spot where a soothing voice lists terrifying side effects while actors smile in a sunny park playing Frisbee.
Or the information comes from the pharmacy insert, which, let's be honest, is not an educational document. It is a legal liability shield.
That is the exact problem. The traditional pharmacy insert is designed by corporate lawyers to protect the pharmaceutical company from litigation.
It lists every conceivable adverse event that occurred during clinical trials, regardless of statistical probability or causal links.
Right. It does not prioritize patient comprehension. It prioritizes comprehensive legal disclosure.
So, practically speaking, everyone in the traditional information chain has an angle. The drug company wants to sell the drug and avoid lawsuits.
And the 15-minute doctor visit is constrained by the sheer economic realities of modern healthcare overhead.
And the wellness influencer on social media telling you to cure your UTI with cranberry extract is just trying to sell you a subscription box.
Exactly. Independence removes the transactional bias from the information. An independent database like iMedix doesn't care if you take a specific brand name antibiotic, a generic, or a holistic preventative measure.
Its sole objective is clarity.
Right. It acts as an unbiased translator between the dense, jargon-filled clinical data and the everyday patient who is sitting on their couch at 2 a.m. in pain, trying to figure out if their symptoms warrant an emergency room visit or just a telehealth appointment?
I think navigating your own medical treatments without an independent platform is like trying to drive in a foreign country without a
Oh,
GPS.
that's a great analogy.
I mean, you might eventually get to your destination, but you are risking a lot of dangerous wrong turns along the way.
And those wrong turns can have serious health consequences.
But I have to challenge the premise that a better database automatically solves human psychology.
Okay, let's hear it.
Let's say you have an incredibly comprehensive, independent drug database. A patient is prescribed a fluoroquinolone antibiotic for a stubborn UTI.
Which is a heavy-hitting class of antibiotics.
Right. They log onto the platform and they read the full, unbiased profile of that drug. They see the very real, very thoroughly documented risks of severe adverse effects, things like tendon rupture, central nervous system effects, or peripheral neuropathy.
Yes, those are documented risks.
So, doesn't providing all that unfiltered access actually induce medical paralysis? How does a platform like iMedix prevent the nocebo effect, where the patient becomes too terrified to take the treatment they actually need to clear the infection?
That is the tightrope walk of medical informatics. If you simply dump data on a patient, yes, you induce paralysis.
That is terrifying.
It is. The nocebo effect, where the expectation of negative side effects actually causes the patient to experience them or causes them to abandon necessary therapy, is a massive hurdle in clinical outcomes.
So, how do they solve it?
The solution lies in how the platform structures the architecture of the information. It requires progressive disclosure and rigorous contextualization.
Explain progressive disclosure in this context.
Yeah.
Because you can't just hide the risks, right? That completely defeats the purpose of independence.
No, you don't hide the risks, but you contextualize them mathematically and clinically. A static pharmacy printout lists nausea and tendon rupture in the exact same bulleted list.
Giving the patient absolutely no sense of proportion.
Exactly. An educational database contextualizes the data. It explicitly states nausea is common, occurring in roughly 10% of patients, and can be mitigated by taking the medication with food.
Okay.
And then it says, tendon rupture is a severe but highly rare complication, occurring in less than 0.1% of patients, typically those over 60, or concurrently taking corticosteroids.
That immediately lowers the cognitive load. You are replacing abstract terror with calculated probability.
And crucially, a robust platform contextualizes the risk of the medication against the risk of the untreated disease.
Right, because not taking the medication is also a choice with consequences. Let's trace that out, actually. Let's look at the domino effect of misunderstanding the disease itself.
Yes, let's do that.
Because the iMedix report explicitly notes that people often misunderstand medication risks, and that misunderstanding doesn't happen in a vacuum. It starts with misunderstanding the condition.
Let's construct a very common clinical scenario based entirely on the contagion myth we discussed earlier.
Okay, set the scene.
A patient develops dysuria and pelvic pain after a new sexual encounter. Because they operate under the myth of contagion, they immediately assume they have contracted a sexually transmitted infection.
Now, despite decades of public health campaigns, STIs still carry an immense societal stigma.
They really do, and stigma breeds silence. If you think you've caught an STI, you're dealing with shame, fear of judgment, and anxiety about having a really difficult conversation with your partner.
And the psychological weight of that shame directly alters their medical behavior.
Exactly. Instead of seeking immediate clinical evaluation for a simple, easily treatable lower urinary tract infection, they hide it. They turn to home remedies.
They drink cranberry juice.
Which is such a classic myth. Cranberry juice contains A-type proanthocyanidins that might mildly interfere with the Fimbria's ability to adhere to the bladder wall as a preventative measure, but it cannot eradicate an established, actively replicating bacterial colony.
So they are essentially trying to put out a house fire with a squirt gun.
Pretty much. They suffer in silence for days, hoping the body just clears it on its own.
Meanwhile, the biological clock is ticking. The E. coli isn't just treading water in the bladder.
No, it is multiplying exponentially. The bladder is a warm, nutrient-rich environment. As the bacterial load increases, the organisms begin to ascend the urinary tract.
They move from the bladder up through the ureters, the tubes connecting the bladder to the kidneys.
And once uropathogenic E. coli breaches the kidneys, the clinical picture shifts from a painful inconvenience to a potentially life-threatening emergency.
We are talking about pyelonephritis.
Yes, pyelonephritis, an acute infection of the kidney tissue itself.
And the symptoms change rapidly at that point, right?
The symptoms rapidly escalate. The localized pelvic pain transforms into severe flank pain in the mid-back. The patient develops a high fever, systemic chills, nausea, and vomiting.
And if this acute kidney infection remains untreated, because the patient is still paralyzed by the initial stigma of the contagion myth, the bacteria can actually cross the highly vascularized barrier of the kidneys and enter the bloodstream,
And then you're dealing with sepsis,
which is terrifying.
systemic inflammatory response syndrome leading to sepsis. The body's immune system goes into overdrive trying to fight the blood-borne infection, causing widespread inflammation
A catastrophic drop in blood pressure.
and potential multi-organ failure, a cascading life-threatening medical emergency triggered entirely because a patient lacked the independent educational resources to understand the basic truth of an opportunistic translocation event.
That sequence of events really underscores the stakes here. Medical literacy isn't just about scoring well on a biology quiz. It is a literal triage mechanism for you and your family.
It absolutely is triage.
And it points to why the iMedix report structures its entire philosophy around three core pillars: medication safety, treatment questions, and patient education. These aren't just corporate buzzwords. They represent a sequence of intervention.
They function as an integrated safety net. The entry point is almost always the treatment question.
Because the patient is driven by an immediate practical need.
Right, why does it hurt? Or can I take ibuprofen with this antibiotic? That specific acute question is the hook that brings them into the platform.
Nobody is casually browsing drug monographs on a Tuesday night for entertainment. They're looking for an immediate solution to a physical problem.
Exactly. So once they are on the platform seeking the answer to that treatment question, the architecture must seamlessly deliver the medication safety protocols.
It provides the dosages, the contraindications, the real-world probabilities of side effects.
But, and this is the foundational philosophy of true medical literacy, medication safety is impossible without patient education. You cannot simply hand a patient a list of rules and expect compliance.
You have to explain the biological rationale behind the rules.
You have to explain the why.
And the greatest example of that, the area where patient education is arguably failing the hardest on a global scale right now, is antibiotic compliance. Let's look at the systemic failure of how we educate people about taking their pills.
Well, this clinical scenario plays out thousands of times a day.
Walk us through it.
A patient is accurately diagnosed with the UTI and prescribed a 7-day course of an antibiotic, perhaps nitrofurantoin or cephalosporin.
Okay.
They take the medication for 48 hours. By day 3, the antibiotic has significantly reduced the bacterial load.
The inflammation subsides, the burning stops, the urgency vanishes, the patient feels completely cured.
And human logic dictates that if the symptoms are gone, the disease is gone. Why continue flooding your body with synthetic chemicals if you feel fine?
Especially if you are wary of medication risks to begin with.
Exactly. The decision to stop the medication early seems entirely rational to the uninformed patient. But microbiologically, it is catastrophic.
What's happening inside the bladder when they stop?
What the patient doesn't realize is that the antibiotic hasn't killed all the bacteria. It has only killed the weakest, most susceptible portion of the colony. The remaining bacteria, the ones that survive the first 48 hours of pharmacological assault, are inherently the strongest, most resilient organisms.
So you've essentially created a localized evolutionary bottleneck in your own bladder. You killed the weak ones and left the gladiators behind.
I love that analogy. You left the gladiators behind,
Huh?
and by stopping the antibiotic, you remove the selective pressure holding them back.
So they just start reproducing again.
Those highly resilient gladiators begin to rapidly multiply, repopulating the bladder. But this time, the entire colony is populated by descendants of the strongest bacteria.
When the symptoms inevitably return a week later, that original antibiotic might no longer be effective.
You have actively contributed to the development of antimicrobial resistance.
Which is currently one of the most profound threats to modern global medicine.
Yes, and this entire sequence occurs not out of malice, and not because the patient is unintelligent.
It happens because they understood take this pill for 7 days without understanding the why.
Exactly. They didn't understand that you must maintain a lethal concentration of this chemical in your bloodstream to ensure the destruction of the bacterial cell walls of the most resilient organisms in the colony.
If a platform like iMedix can bridge that specific gap, if it can provide the dynamic, accessible explanation of why the 7-day course is biologically necessary, it isn't just improving an individual's medication safety.
It is actively contributing to the preservation of global antibiotic efficacy.
That's incredible. If you take that a step further, the education doesn't just stop at compliance, it has to extend into prevention.
Prevention is the holy grail.
Because if we are trying to minimize the use of antibiotics in the first place, we have to address the people who get caught in the cycle of recurrence. Some people get one UTI in their life, and it's a minor footnote.
Right.
Other people seem to be battling them every other month. Why the massive discrepancy?
Recurrence is a complex interplay of anatomical predispositions, behavioral habits, and bacterial defense mechanisms.
Let's break those down.
Anatomically, some individuals simply have variations in the distance between the urethra and the anus, or variations in the mucosal lining that make it easier for bacteria to adhere.
Okay, so just structural differences.
Right. But the most fascinating and arguably the most frustrating aspect of recurrent UTIs involves a microscopic survival strategy utilized by UPEC known as biofilm formation.
Biofilms. This sounds like something out of a science fiction novel. It's not just free-floating bacteria, is it? It's an organized structure.
It is highly organized. When UPEC enter the bladder, they don't just float freely in the urine.
They use the fimbriae.
Yes, they use those fimbriae to attach to the umbrella cells lining the bladder wall. Once attached, if they aren't flushed out, they can actually invade the host cells.
They go inside our cells.
Yes,
Yeah.
and once inside, they multiply and secrete a polymeric extracellular matrix, a sticky, protective fortress around the colony. This is the biofilm,
It's literally a microscopic bunker.
and it operates exactly like one. Inside the biofilm, the bacteria engage in quorum sensing. They actually communicate with each other through chemical signals to regulate their growth and coordinate their defenses.
They are communicating.
Yes, more importantly, the biofilm acts as a physical barrier. The patient's white blood cells cannot penetrate it,
Wow.
and many standard antibiotics cannot effectively diffuse through the matrix to reach the bacteria inside. Furthermore, the bacteria deep within the biofilm often enter a dormant metabolic state.
Why does being dormant protect them?
Because many antibiotics work by disrupting active cellular replication, like interfering with the construction of the bacterial cell wall while it's dividing. Dormant bacteria aren't dividing, so they're essentially immune.
So a patient could take a full course of antibiotics. The free-floating active bacteria in the urine are completely eradicated. The patient feels fine.
The urine culture even comes back clean.
But the bunker is still there, embedded in the bladder wall.
The biofilm remains intact. Weeks or months later, triggered by an environmental shift, perhaps a change in urine pH, physical stress, or another mechanical transport event, the dormant bacteria inside the biofilm reactivate.
They break out of the matrix.
They break out, re-enter the bladder environment, and initiate a massive secondary infection. To the patient, it feels like they caught a brand new UTI.
But microbiologically, it is the exact same colony launching a coordinated second wave. The biological reality of that is terrifying, but it also highlights why patient education surrounding behavioral prevention is so incredibly critical. You can't out-medicate a biofilm easily, so the goal has to be preventing the bacteria from ever having the time to build the fortress in the first place.
Exactly. The preventative measures often sound like folksy wisdom, you know, but they are grounded in rigorous physical mechanics.
Like drinking water. Everyone says drink more water.
Right, hydration is paramount. Drinking copious amounts of water ensures a high volume of urine production. This isn't just about diluting the urine, it is about mechanical force.
Frequent high-volume urination constantly shears the bacteria off the bladder wall before they can firmly anchor.
Before they can even begin the complex process of forming a biofilm.
It's like constantly running a fire hose over the driveway to keep weeds from taking root in the crack.
The mechanics are very similar. The second major preventative behavioral modification addresses the mechanical transport of sexual activity.
So urinating immediately after sex.
Yes, the clinical recommendation to always urinate immediately after intercourse is designed to utilize that exact same mechanical flushing action to wash out any native flora that was just inadvertently pushed into the distal urethra.
And thirdly, the fundamental hygiene practice for women of wiping from front to back.
It is entirely about minimizing the introduction of colonic E. coli to the vaginal and urethral microbiomes.
These interventions are completely non-pharmacological. They cost nothing, they carry zero risk of adverse side effects, and they don't contribute to antibiotic resistance.
But they require an active, educated patient who understands the mechanics of their own body.
They require a patient who has moved past the myth of contagion.
And that transformation from a passive recipient of medical directives into an active, informed participant in one's own health, that is the ultimate objective of a platform like iMedix.
They are building the infrastructure necessary to facilitate that transformation.
Yes. By providing an independent, accessible, and contextualized database, they are attempting to break the cycle of medical misunderstandings that lead to unnecessary suffering and systemic medical failures.
We have covered an immense amount of ground today, tracing the journey from a simple question typed into a search engine to the complex realities of microbiology and global healthcare infrastructure. Let's quickly recap the major through lines of this depth dive.
We began by unpacking the core themes of the iMedix report, confronting that persistent, ubiquitous myth that a UTI is a contagious disease.
We established that biologically, the vast majority of these infections are not external invasions, but internal, opportunistic translocations of native E. coli from the lower gastrointestinal tract to the sterile environment of the urinary system.
From there, we explored the dangerous conflation of UTIs with STIs, detailing how the mechanical friction of sexual activity acts as a transport mechanism for your own flora, rather than the transmission of a foreign pathogen.
And we examine how the stigma and shame associated with that misunderstanding can cause patients to delay treatment, setting off a dangerous domino effect that can lead to severe kidney infections and even systemic sepsis.
We then analyzed the systemic communication failures within modern medicine, the 15-minute clinical encounters, and the legally driven, impenetrable pharmacy inserts that leave patients so vulnerable to misinformation.
Which led us to the critical need for independent platforms like iMedix, which utilize intelligent database architecture and progressive disclosure to contextualize risk and prevent the nocebo effect.
Finally, we looked at the microbiological reality of why patient education is the ultimate bedrock of medication safety.
We discuss how misunderstandings about antibiotic mechanics contribute directly to global antimicrobial resistance, and how understanding complex concepts like bacterial biofilms empowers you to utilize behavioral prevention to break the cycle of recurrent infections.
Ultimately, the report demonstrates that demystifying the basic mechanics of our bodies is the first, most crucial step toward true medical safety.
It all comes back to stripping away the myths so that the truths can be weaponized for your own protection. Which leaves us with one final provocative thought for you, the listener, to mull over as you go about your day.
I'm ready.
We've just spent this time dissecting how a completely ordinary, incredibly common bodily infection has been shrouded in so much societal myth and psychological misunderstanding that an independent platform had to build an entire dynamic database just to help us navigate the basic anatomical truths of our own bodies.
Yeah, that's wild to think about.
So my question for you is this. If we can be so collectively, fundamentally confused about something as standard as the mechanics of a UTI, what other foundational beliefs about your health, your daily routines, or the medications sitting in your cabinet right now are you accepting as undisputed biological fact that might actually just be a well-disguised myth waiting to be debunked?